We're going to move now next to a virtual talk from Jung from Dusseldorf. So we have him online, and let's talk about the microcirculation versus the macrocirculation in shock.
Thank you very much. Is audio and video okay? So otherwise somebody has to stop me. Good morning from Düsseldorf, Germany. We have sharp after midnight, and unfortunately I cannot personally be with you, but my best greetings to the Houston Shock Symposium. And dear Marwan, dear Chairman, thank you for inviting me. Ladies and gentlemen, dear colleagues, the next 7 minutes I will talk about the micro and the macro circulation in cardiogenic shock. And the border between micro and macro circulation along the vascular tree is the vessel diameter of 100 micrometers. All shocks share a vicious cycle around an impaired microcirculation, and this is the place, as you all know, where organ function is determined, where organ perfusion is warranted, and where organ failure is determined. And in cardiogenic shock, this vicious cycle is entered via a reduced cardiac output, leading to hypoxia and acidosis, anatonia of the capillaries, and a relative hypovolemia. And all this corresponds to microcirculatory disorders. How to assess the microcirculation? In this review, the diagnostic tools to investigate the microcirculation have been summarized, but in this 7-minute talk I will only focus on serum lactate and intravitreal microscopy on the bedside. As you all know, lactate is the alarm marker, and in this large cohort of critically ill patients, already an increased lactate and increased very low lactate levels above 1.4 indicate an increased ICU and hospital mortality. We confirmed that in the ERBP Shock 2 trial together with Holger Thiele, who was already with you today, that this is also true for cardiogenic shock. And we described and investigated that the best cutoff value regarding 30-day mortality is a baseline serum lactate level of 4.6. Assessing lactate can also be done using the lactate clearance, and there are different strategies doing that. And in this large cohort of more than 7,000 patients with increased lactate levels, we compared different strategies. And one example is, for example, assessing the delta 24 lactate levels. This means comparing the maximum levels on day 1 with maximum levels on day 2. And you see that there's a very dramatic difference regarding the prognostic role regarding short and long-term mortality. How does it look in cardiogenic shock? And we investigated this in the combined cohorts of the ERBP Shock 2 and the Culprit Shock trial. Using this, we were comparing the baseline lactate levels, indicating that this can discriminate survivors and non-survivors. You can also do that using baseline values and comparing that with the 8-hour values, calculating a clearance, which leads then to a decrease in lactate levels in survivors and a negative clearance in non-survivors. And also the crude 8-hour values can be used to discriminate non-survivors and survivors. And of note, comparing the area under the curve for these values, it is best for the crude 8-hour values, and this can be used in our daily practice, obviously the best in order to assess prognosis. I mentioned that also intravitreal microscopy can be used, for example, using this device, but there are different devices on the market. And Daniel De Backer is with you in Houston, and he was actually the first using this device and making a detailed description of an impaired microcirculation, in this case in septic shock. and you can assess from these images that a normal microcirculation is very much different to an impaired microcirculation in shock. Not only the rarefication, but also the impaired circulation in these vessels. And we also did that in cardiogenic shock patients, and you can derive these images from the sublingual mucosa directly on the bedside of the patient. And for example, assessing this in cardiogenic shock patients, you can see that I will not go into the details of how to analyze it, but a sustained microcirculation is associated with very low mortality rates compared to high mortality rates with impaired microcirculation. And even we were able to predict future lactate levels in these patients. So it is important to summarize also with some other talks today that in cardiogenic shock, the micro and the macro circulation are impaired. And it is of crucial importance to assess how our treatment strategies affect not only the macro, but also the microcirculation. And as one example, I can highlight the catecholamines under these circumstances. And you have heard the talk by Dr. Estuvorovic, who mentioned, for example, that epinephrine is not the first choice catecholamine in cardiogenic shock, since it mainly also affects the microcirculation with strong vasoconstriction, limiting organ perfusion. So this is of crucial importance, thinking about the microcirculation. We can also use this in a translational approach, for example, in clinical studies. And I would like to come back to the topic from Dr. Bilya, who mentioned therapeutic hypothermia. And we did a clinical study using therapeutic hypothermia in cardiogenic shock patients, which was a neutral study, but we assessed the effects of hypothermia in a randomized controlled trial on hemodynamics in the macrocirculation, for example, using here the cardiac power index as the primary endpoint, but we also used the microcirculatory parameters as endpoint in this clinical study. So how to use it in our treatment. So the macrocirculation often refers to blood pressure. So vasopressors and inotropic support should be titrated to a mean arterial pressure of around 65, but not higher. That increases the vasopressor use. And in the microcirculation, it is more complex, but lactate is one strategy, and we need to think about that in our treatment and to try to sustain microcirculation as organ perfusion. With this, I would like to summarize. Macro and microcirculation are important in cardiogenic shock. Microcirculation is relevant for organ function and prognosis. Serum lactate might be our daily life parameter for the microcirculation, and the crude 8-hour value might be used best for outcome prediction. And our treatment should consider the consequences also on the level of the microcirculation in order to do the best for the treatment of our patients. With this, I would like to thank you for your attention, and I'm ready to answer your questions.
Daniel, maybe we'll start with you, the king of microcirculation.
Well, so thank you, Christian, for this very nice talk. And I think that in 8 minutes it was very difficult to summarize all the literature there, because indeed there have been several studies showing both in sepsis but also in cardiac shock that indeed it has a very important role in prognostic of the patient. The problem of the microcirculation in cardiac shock is to know whether it is influence driven by the macrocirculation or whether the factors influencing the systemic circulation are also in a separate way affecting the microcirculation, so that at some point the microcirculation is becoming dissociated from the macrocirculation, and even when we correct the systemic circulation, these microcirculation alterations may persist and may still be leading to some trouble in our patients. And I think that this is a key element. We do not have exactly right now the response. And it will be important, of course, because when we will be thinking to how to try to correct it, of course, the first line will be to try to correct the systemic hemodynamics. But when the microcirculatory alteration persists, the question will be how to intervene at the microcirculatory level. And this becomes a bit more tricky. And I would like to know for Christian, what would be your therapeutic options in cardiac shock more specifically?
Daniel, thank you. I mean, you perfectly summarized it. We don't have a specific tool to correct the microcirculation, and what you have just summarized, the possible incoherence between macro and microcirculation is a true problem. To answer your question, I mean, it's best to think at the bedside that you need to optimally correct both, and this what we can do best is, for example, to save vasopressors in order to have the best macrocirculation and the best blood pressure, but even not more, in order to also then correct the microcirculation with the lowest level you need, for example. And vasodilators would be best, and that might be also a part of the next talk, as I saw in the program. So improving perfusion should be the target, and thinking about the microcirculation while planning the treatment. I'm sorry, I don't have a specific treatment strategy for that.
So Christian, we have a question from Bimraj, and after that we have a question from the audience, and Dr. Vorovich also. So Dr. Bimraj.
You know, again, I think this is the kind of the future target that makes sense. My two questions are, as the circulation becomes smaller, the capillary endothelial cells are more sensitive to cyclic strain and pulsatility, and then also temperature changes. Do we know from all these studies on how continuous flow, is it impairing the microcirculation? And then how about hypothermia? When we're trying to save the brain and the body, are we actually hurting the microcirculation? Is there any insight?
We saw in the shock-cool trial that there's no difference regarding the perfusion and the microcirculation, although we of course think that the vasoconstriction occurs with this treatment. But there's no difference in the functional perfusion with hypothermia. And of course I also agree on the point that this is a future target for treatments and so on. We really need to dig more into that. I completely agree.
So I enjoyed this talk. Now the lactate is non-localizing, right? So is it important to know which circulatory bed this is coming from, or is all lactate bad and that's what we know, so if it goes away it gets better? Because we're obviously using it in this context, but we're really not knowing where it's coming from and what's causing it.
Yeah, you're right. So all lactate in general, as we know as clinicians, is in the first place a bad lactate, and you need to try to get rid of it, but not to make the values better, but to improve perfusion. In general, in these studies, it's not really targeted where this lactate is coming from, and it can be seen as a whole body problem, although it might be derived, of course, from different vascular beds. And there are some specific scenarios, for example, if you have an impaired hepatic function and so on. But in the general patient, all increased lactate is bad lactate.
Esther and David.
So I have kind of a two-part question, and I'm going to include Nir in the question as well. But so you said that we should be targeting the least amount of pressors to get the goal that we want, and we have a goal of 65, but there's not a strong base of literature to say 65. So one could make the argument that what we're trying to, we're using 65 as a surrogate of perfusion, macro and micro. And do we have, or is there anything on the horizon of wearable devices that could, and this is why I'm including near. I don't know if you can see me, I'm looking at near, of wearable devices that could help us at the bedside as clinicians be able to assess microcirculation, say, oh, actually, this person's doing fine at a MAP of 55. Maybe I can turn down my non-epi Levofed, right, or whatnot. And I think that would be very helpful. I'm just curious if you know of anything on the market.
So Christian, maybe you will want to take it and I will give a comment about it after.
Yes, sure. I completely agree on that. So what guidelines recommend is a MAP of 65, but we don't have real evidence for that. And but this is what guidelines say. The answer to this outside guidelines is that you have to maintain good macrocirculation that, as in line with Daniel said, that maintains microcirculation, that all organs are perfused. And also in some patients, we also know these patients on long-term chronic dialysis that have much lower blood pressure values, for example, they are happy with that. And you can also let the pressures drop to 55 and the patient is awake and has good renal perfusion and so on. And that's I totally agree that this is completely fine. And there are devices in development in order to assess this microcirculation, as I illustrated, in a much easier way. So this is for studies and clinical studies, and we also have randomized trials ongoing in order to show some kind of decision helping algorithms. And I'm happy to exchange thoughts on that also in clinical trials that you might plan. But this is not easy to use. And there are devices in development that can assess the perfusion at the bedside much more easily, and that, but you need to have some access to an easy to assess vascular bed, for example, the sublingual mucosa or something similar.
So just to answer Christian, there is also some trials now to try to assess continuous lactate. Meaning to get a continuous lactate as a parameter that's actually going to give you. And of course, the caveat here is the half-life of lactate itself, because you produce lactate, it takes time until you clear it. So it's not like oxygen saturation that is something that is really going on. Blood pressure, as you mentioned, it's much more on the macrocirculation. Whether the waveform itself of the macrocirculation can give you a clue, the chrotic notch and the waveform itself, on microcirculation, it's still something that causes a lot of interest to a lot of people, because we think that actually there is much more information derived from the macrocirculation blood pressure, central and peripheral blood pressure waveform, and of course they are different. I know that there is a lot of questions. Maybe we'll keep it for
She got it.
She got it. So because we really, Christian, thank you. We sorry we miss you here in person.
Good night. Good night.
Yes. Try to get some more sleep before work.
Take care all.
Bye.